Hello everyone and welcome to the Prosthodontic webinar series. My name is Omar and I am the webinar director at Score Committee. It's a pleasure to have you all with us today. Briefly, the International Association of Dental Students (IADS) is the largest global organization representing dental students worldwide, connecting students across countries and promoting academic exchange and professional development. This webinar is organized under the SCORE Office of IADS, which focuses on research, education, and international collaboration, providing students with valuable global learning opportunities. We are delighted to have you join us today, and we hope you find this session insightful and beneficial. Without further delay, I will now hand over to my colleague Sophia to continue the session and introduce our professor today, Prof. Ali.
Hello everyone, my name is Sofia and I'm the webinar coordinator for today's session. And it's truly a great honor to introduce our distinguished speaker today, Professor Dr. Ali. Professor Dr. Ali graduated from Hissipti University Faculty of Dentistry in 1998 and completed his PhD in prosthetic dentistry in 2004. Throughout his remarkable academic journey, he has served in several prestigious institutions, including Yeditepe University and Richard Friedrich Wilhelm University in Germany, where he worked as ITI scholar in oral, dental, and maxillofacial surgery. He was appointed associate professor in 2012 and became a full professor in 2018 in the Department of the Prosthodontics. Currently, he is the PhD program coordinator for prosthetic dentistry at Istanbul IDA University, while also continuing his clinical work in private practice. Professor Ali has a strong focus in digital dentistry, partially limit veneers, and implantology. He has published numerous articles in international peer-reviewed journals, delivered many lectures and courses worldwide, translated 8 books, and he also translated 8 books into Turkish and contributed chapters to books on implant dentistry. He has been an ITA fellow since 2011 and has held several leadership roles within the ITA Turkey, in addition to being a member of the ITA Board of Monitors. Without further, please join us in warmly welcoming Professor Dr. Ali, and all the mic is yours.
Thanks so much for your kind invitation. It's always exciting to be with the young generation to share your passion, ideas, and what you have been through throughout the years. And as you have mentioned, I was graduated in 1990, which means that almost 30 years ago. So what I have learned has changed a lot during my career. And every year I have to learn, adapt, forget, and relearn again. So I think when you are starting your careers and you have a very fresh and interesting journey on your future. So I'm going to share what I'm doing today, not what I did 30 years ago, not what I did 10 years ago, because what I'm going to share today is the digital dentistry and how I get benefit from the artificial intelligence in terms of using the softwares, and also how to implement them to my daily practice with the novel technologies, adopting novel materials and workflows to our daily routine. The problem about the technology is it's challenging to adapt the technology with the help of evidence, with the scientific evidence, because the technology is way faster than the evidence. This software is getting outdated. The materials needs to be followed up almost at least a year to give an insight, a reliable insight. And in the time of 3D printing, and every day we are facing with new materials, novel technologies, novel scanners and workflows, and we have to be a little bit cautious about adopting the technologies. And this also requires a little bit of learning curve, but they're not very, very hard. They're not challenging. Only way is to use them, to see them as an aid, not the aim. I'm not going to talk about digital dentistry as the very aim of my routine procedure. It is just an approach, it's just a way to do the best for the treatment of any patient. So having said that, let me start my presentation. I'm going to talk about no application, no materials. And as you have already introduced me yourself here, I was born and raised in Turkey, and I was a scholar in Germany back in 2009, where I had the surgical notion. And since then, 2013, I'm into digital dentistry. And since I was introduced to digital dentistry, starting with chairside workflows, now I'm implementing to the printing and also other technologies. What is new? What is going to be used for the next time? I wanted to try the first hand. This is a bit painful. So you have to also face the challenges before everyone faces it. But it's good to have these ideas and have this experience so that we can communicate and I can share my experience so that you're not going to do some mistakes and you get better and better every day. This is my playground. It is changing almost a yearly basis. For now, I'm using 3 intro scanners in my daily practice. One of them is PalmScan. It is a chairside technology with a milling machine. I have also Lumina for my full arc restorations. And also I have implemented recently the Sirius X3, which is also combined with additive technologies, additive production technologies. Do I need them? Do I have to use everything all at once for every single case? No. When it comes to investing your future, you're going to face that a lot of technologies, a lot of materials will be presented. And because of the speed of the time, we have this FOMO, fear of missing out. When you go into the social media, the Instagram, the Facebook, we're seeing new technologies, new materials, new workflows every day. And when you don't have one, you feel that you cannot easily achieve the best result. You can achieve the best result with what you are using at its most, at its best. So we're in the 4th industrial revolution, which is the cyber physical systems. In a very brief summary, cyber physical systems is what digital dentistry is. The computers help us to think, to evaluate, to design, but we need production, we need milling machines, we need our hands to provide the solution, to provide the treatment, the restorations to the patients. So our mind and the computer get together. Human intelligence plus artificial intelligence also combines human milling or human manipulation with the robotic manipulation. We can call it additive or the subtractive production methodologies, and we produce the restorations. What has changed, what has not changed? As you can see, a nice example. When I started listening to music, I was using the cassettes, so I was not having the LP era. I was not in that era. So I started using my Walkman and etc. And then we have switched to compact players and to iPod, and now you're using streaming. What has changed? The music doesn't change. Like the biology, it doesn't change. The human being does not change. What changed is the medium, which means that this is the message. The message of today is all of them is going to give you more or less the same result, the same tune, the same music, the same sound. But you may lose some accuracy, or you may lose some delicacy when you are going from a CD to a streaming. And also it defines another important issue. It also defines how to consume fast. Our patients are not so patient now, and they want to have the result all of a sudden. This is why they're searching to the immediacy. And immediacy in implantology is also a nice thing because you have the opportunity to protect tissues you're dealing with. But you have to precisely execute your plan to be successful in immediate restorations. The patients are correct if they want the best at the limited or the smallest time frame. And with the help of technologies, I think we can do that. But whatever methodology, whatever production facility we're using or workflow we're using, we should not give compromise from the trueness and the precision, which is defining the accuracy. As you can see here, we are seeing interesting, very nice calibers for a watch. They're automatic and mechanical watches. They are so delicate artisan. It requires craftsmanship, and they're very accurate. 1 or 2 seconds per day. When it comes to the quartz era, this type of accuracy about measuring the time has become way better. So we have up to 1 second of inaccuracy with the quartz, but now we're also using the smartwatches. The smartwatches are not only accurate because they are getting the data about what time it is from the atomic watches, and instantly they're calibrated compared to the quartz or the automatic watches. They also define another way of thinking, the digital way of thinking. This is not a watch. This is not a time measurement piece. This is not a chronometer. This is an idea. This is a gadget where you can see your practice. This is where also can access you to the other world. It defines another mentality. But whatever it is, even you're dealing with the analog way or the digital way, we need a plan. Back in 1990, when I started doing implantology, we were planning, and the old labels were also mentioning about how to plan. First, you need a prosthesis, which has been made on a cast. Either you take it with an argent impression or etc. Then you make some kind of try-in, you go into patient's mouth. For an edentulous case, you see the change in the profile. We go to have an x-ray, and then the x-ray also has some tubes with radio-opaque tubes, and we all combine where the teeth are. We can see that on an x-ray or a 3D DICOM data, which means that we had a plan. Not any architect in the world or any construction would be built without a plan. The plan is first in 2D with a floor plan, and 3D like a mock-up. Then we execute the plan to the real world. The architecture is very, very same as Prosthodontics. With the help of artificial intelligence and also with the large language models like ChatGPT, with writing the right prompt, you can see the changes in the 2D, which can upload a photograph, and then the picture can also help you to make a 2D planning. But 2D planning means nothing unless you make a mock-up and go into the patient's mouth so that the patient can feel the change and also see what is going to happen in the end of the treatment. It will be a 3D model. Why is that? Because we are also living in the age of biomimetic era. And when you go into textbooks, and when you're going to see that back in 2000s, starting of 2000, we are seeing perfectly placed, perfectly aligned, bright white teeth. But now you're going to see that when you go into textbook by Belzer and Manian, for example, and the book is called Biomimetic Restorations. We are trying to copy and mimic the nature, what we have in natural life. Why is that? Because the form follows the function, and the form also is the main ingredient in the aesthetic workflow. And the biomimetic approach requires having some biometrics. Biomimetic restorations should have dimensionally the same, more or less the same dimensions, also the ratios, but most important, the form of a natural tooth. And also, the biomimetic restoration should mimic the optical characteristics of a natural tooth. Those can be calculated, and we are using biometrics. And when it comes to biometrics, the first software I'm going to show you is the SmileCloud 3D&A. With the help of AI, it's possible to merge a portrait photo of a patient with an intro scan to make a good planning. As you can see, I have uploaded the portrait photo. The smile has already been aligned with the intro scan. The intro scan is manually adjusted. And then I can add the lower jaw, as you can see from here. And the lower jaw can be aligned with this digital patient using the byte registration, or you can also align with the portrait photo. I upload the CBCT because you have seen that the patient has a missing lateral incisor, and we can also generate a motion. Whatever we do, whatever restoration we create is not fixed and only does chewing, open and close. We have to have an understanding of the mandibular motion when we are designing our plan. Now I have the three-dimensional intro scan and also the CBCT aligned and registered. And the SmileCloud software gives me a proposal about the smile design in 3 dimensions and also 2 dimensions. When I play around with the 3-dimensional placement of the tooth virtually, I also play with the portrait photo, which is very important to have an understanding, to communicate with the patient what they're going to see in the end of the treatment. And also, when we are playing around with the intro scan and the photo in front of the patient, with the patient, we create a team. This is the essence of success in restorative workflows, making the patient a part of the story, make them contribute. The artificial intelligence not only helps us to make a nice smile design planning, it also helps us to create a jaw motion. We're going to see the example again here. Another patient, the patient has his intro scan, and also the patient has, as you can see from here, some abrasions and adhesions, which requires a development in incisal edges. I have to lengthen the tooth, and also I have to correct occlusal plane. But to correct occlusal plane and make the anterior teeth longer, I also have to consider about the protrusion and retrotrusion. And instead of making a mock-up and making the adjustments in the patient's mouth, I can create the jaw motion with the help of artificial intelligence by a software embedded in SmileCloud, which is called the Bite Finder. And while I'm playing in motion, I can edit, I can place the tooth, I can play with the positioning so that I will prevent any interference, first virtually, and then in real life, to a better planning. In this video, you see the live action and also the created motion. It needs some time to learn. Artificial intelligence is learning. The algorithm is getting better, and this is a learning progress. This algorithm gets better with the data you are uploading and the data you are supervising. Artificial intelligence, the large language models, do not go into the final decision without the help of a human. They are going to need the human intelligence, the human experience, and also the knowledge we have until now. needs to be used to supervise and also correct and adjust the result the artificial intelligence is producing so that they're learning. Bytefinder or some similar softwares, an interesting feature, which is without having the byte registration, you just upload the both STL files of the maxilla and the mandible, and the algorithm matches the surface areas of the both jaws, or the indentation marks on the teeth, the occlusal aspects of the teeth, and creates the best possible maximum intercostal position, and also creates the best optimal lateral and protrusive jaw motion. 80 to 90% accuracy compared to zebras or mojo. Artificial intelligence is helping us to have an understanding of the patient in the planning phase. This planning phase is very important. It's essential to create a live mock-up, which is going to be tried in the patient's mouth. And after we do the adjustments, we rescan what we have and finalize what we are going to do. It's very easy to copy it. Artificial intelligence not only helps us with the occlusion, it also helps us to make a design in the workflow. This is Denver, a software which you can use for your crown or implant designs. What you need to do is uploading the scan, the maxilla and the mandible, even partial or the full scan, upload it in the cloud. And the system, the software, automatically defines the margin, defines what type of restoration this case requires, and makes the design on its own, but needs supervision. You'll have to, again, correct or adjust the margin, and also it's easy to play with the dimensional other frame of the restoration, but it is very important to have less time for adjustment. The good thing about artificial intelligence software is they're helping us a lot. When it comes to segmentation of any CBCT, the human segmentation takes more or less 20-25 minutes for a given DICOM data, but the artificial intelligence can finish the segmentation into 3 minutes. The 70 minutes you gain, you can use for better treatment. You can use for better planning, better thinking to find a solution. And also when it comes to morphological accuracy, this review showed that the most frequently reported good outcome is the morphological accuracy for artificial intelligence designed dental crowns. Of course, they need some room for improvement about anatomical varieties. And also it's hard to standardize the evaluation protocols. We need further studies. But 2 years ago, we had only one software to do this type of design. Now we have more than 3-4 softwares. Atomica, Denver, 3Shape Atomica, 3Shape Automate, sorry, and also Exocad AI can do the design on their own to have the technician or the practitioner have more time for treatment, more time for planning. This is the greatest advantage. And also, when it comes to having the learning concept, the artificial intelligence-driven automated design of anterior and posterior crowns under diverse occlusion scenarios, which require, as I said, the versatility. We see that the artificial intelligence is quite extremely helpful to understand, to differentiate the different occlusal scenarios. And as you can see from here, the upper hand side with the yellow models, you see that all of the molars are being located in terms of buccolingual aspects in the right position, where the computer-assisted algorithms, human intelligence plus computer assistance, not full artificial intelligence, they're not using, which like Exoket or Cliche Studio, you're seeing that the molar can be located in an angulated or not upside down, but under posterior position, fully rotated. The algorithm can understand, can detect what we have, and gives us a good morphological accuracy. And the studies show that crowns with excellent seating, adaptation, and occlusal relationships are more likely to be successful in the long term than those merely matching geometric ideals, which means that the studies show that reveal that Exoket can create incredibly perfect anatomical variations. But when it comes to accuracy with excellent seating, adaptation, and occlusal relationships, AI started outperforming computer-assisted human intelligence. This is very interesting. And also, another nice study showed that commercial available artificial intelligence-based and conventional human expert-based workflows, we see that when it comes to reproducing the dimensions and also the anterior guidance and post inclinations with the help of AI, although the artificial intelligence still has to learn to create more artistic restorations in terms of 3D-dimensional restorations, they can give incredibly comparable results about proximal contact length and with height ratio, and also about the opportunities to have that better fitting restoration. Or we can mirror symmetrical tooth. We can use the libraries, or we can copy the mock-up with the help of softwares. In this example, you're going to use the library. The patient has old crown, they have been removed, and the preparation has been made, and software automatically detects the margin line. Again, to detect a better margin line, you have to have good margins, visible margins. The intraoral scanner is nothing more than an eye. What you see is what you get. So retraction, having nicely smooth but well visible margin finish lines is essential, not only for conventional workflows, also for digital workflows. And then thus, digital workflow requires better dentistry, better angulation, because it also relies on the accuracy, or let's say the performance of creating better room for a given material to have more strength, to have a long lasting restoration. And the library offers us, proposes us 4 crowns here, and it also gives us the option to edit with the help of editing tools. I may suggest you to play with some softwares to have more literacy about digital dentistry. They're free. Mesh Mixer, Nomad, they're not dental, but you can use that type of softwares to play with STL files, to understand how to make the design, how to edit the design, because all prosthetic design softwares are using more or less the same tools, like we are doing, like we are using in practical level. when you're playing with the wax, we do three things. We add the wax, we remove the wax, or with the help of flame, we smoothen out the wax. This is the basic idea of the digital design programs. And also with the help of these softwares, when you get better understanding of how to use the tools, you can use them on the professional level way better. And it's also uploading the cases and also playing with the cases with this Denver software or many software like Blue Sky. You can upload, you can play, you can learn. And when you learn, when you play with the anatomy, then this information is not only efficient to have better technical work, it makes you to understand the morphology, the anatomy better, to understand the thickness of the material better, to understand how to make a good preparation, to a well-fitting restoration better. So you start understanding how to make good dentistry and how to create good environment for the technician to have better results. As you can see here, the restoration has been designed and ready for milling or additive production. This patient has some issues with her central incisors. I have started with making a little mock-up. The central incisor, right-hand incisor, required a little gingiviectomy, and 1 week later, I have better soft tissue, but now I have a way to communicate with my patient, to understand what will be the end result. This is very important, even for implant restorations or for natural tooth restorations, to having an understanding of what we are going to have in the end, and before starting everything, to have at least an image, a way better than image, a 3D mock-up to see in the patient's mouth, to try in the patient's mouth, is essential so we can communicate better. And according to this final three-dimensional end in the patient's mouth, we can do backward preparation to create room for the restoration if it requires a crown or if it requires a laminate veneer to make less harm to the patient, as Kökat said, then it's also possible with the digital technologies to copy our mock-up for our final design and also play with it. As you can see, we had some issues about the symmetry. The central incisor in the right-hand side has more triangular shape, and the left one was a bit, rectangular shape. I see that. I may not understand it when I'm doing it on live mock-up session, but when you're done, you have to take photos and videos and take a breath and re-criticize yourself. What should I do? How do I get better? What should I change? And with this thinking in your mind, you go for the final stage, then design accordingly. Of course, we need a train. As I use chairside technologies a lot, I do not use models and dies, etc. most of the time, but please remember that the softwares can also give you the option to create the models, the dies, and also the 3D samples to be printed for a pre-trying in the patient's mouth with just one click with the help of artificial intelligence. All of them can be produced by AI with one click, so the expert will end up with the trying. When the patient has this in the mouth, and then you see the fit, and you see you're going to play with them. The next step is to make a natural looking restoration. We are using Monolithic restorations in the era of digitalization because what we plan is what we get. It's not like having the ligate and the powder and mixing them and applying with a brush, layering and going to the furnace and having and dimensionally changing or shrinking and playing and doing it again and again, which requires extreme artisanship and experience. This is why we should admire a lot, and we should be very thankful to our ceramists. They're very important people. They are very talented people. They're the ones who are creating the natural looking restorations. But in the age of digital dentistry, digitalization, you're using monolithic restorations, and monolithic restorations are produced by a milling machine or 3D printed restoration. They require, again, the human touch to have a better natural look. And to have a natural look, we can use the type of burst and type of this polishing cups or wheels to create the texture, to play with the optics. When you are playing with the texture of the restorations, you have the opportunity to show them thinner, thicker, wider, or angulated, to play with the light transmission and also playing with the reflection of the light, with creating some ridges, some sulcuses, some indentations, and also with the help of liquid ceramics, without the need of layering. We have the opportunity to make a monolithic restoration. Like you can see here, this is a lithium disilicate, an Emax. The Emax is a lithium disilicate which has 500 megapascals of flexure strength, and you can use it not only for crowns and laminate veneers, also you can use them upon an abutment for an implant restoration. You can use them as a solution for 3-unit bridges to second premolar with only one contact. They have nice translucency, but not enough translucency. They are monolithic, monochromatic. To make them looking natural, we can use liquid ceramic instead of layering them, doing any cutback and add-on. You can create the optical illusion of having a halo effect, the translucency, and also the mammalian effect. So we can end up with these type of restorations for a crown or for a laminate veneer, completely identical, natural, and biomimetic, with the planning to the end. When it comes to implantology, planning and using these type of softwares and digital technology is more essential. In this case, I'm going to have an immediate restoration, immediate implantology procedure for the central incisor, because the patient has a fractured tooth. And before I start everything, I go into softwares, make an impression, make a CBCT, make the final crown to have a planning for the right gingival height for aesthetically pleasing and natural looking, and also biologically sound abutment and three-dimensional implant positioning according to the final prosthesis. The data is being segmented, and after having the best plan in mind, even with freehand or with guided surgery, the implant is being placed in its final position, and immediately, first we can have the opportunity to replace the central incisor for the patient, and 3 months later, we have the opportunity to create this natural looking central incisor with a good plan. In digital world, we have two production options. One is subtractive, one is additive. 3D printing versus 3D milling. What is the main difference? The main difference, mostly the main difference, is the material. We cannot print everything. We can use additive technologies, additive printing technologies for mostly resin materials and zirconia, reinforced resins, or up to some ceramic resins, which more or less 70%, from 50%, 70% of ceramic plus composite restorations can be produced with additive technologies. When it comes to subtractive technologies, we don't have any limitations. We can subtract anything we at all. But the idea is different. When you're producing something with the subtractive technologies, you're using milling machines with 3, 4, 5 axes with a rounding burr, which means that you cannot produce very sharp angle in the intaglio surface. But with additive technologies, you can create whatever you want. But both requires a gap for cementation. Both requires a way of thinking, digital, to have a better restoration fit regarding the intaglio surface. A crown has been prepared, and let me show you the biggest difference. I have designed, and as you can see, the intaglio surface, when I go for, say, 50 microns of cement gap, intaglio surface is completely the same with some offset regarding the preparation, and it's for 3D printing because I can produce it. But when it comes to milling, according to the thickness of the tip of the milling machine and the axis, I may have under milling or over milling, which may end up with inaccurate seating or no seating at all, or some extra gaps. Why I'm saying that? Because most of the universities in the world are teaching based on the books, which has been used for ages, and the methodology of the preparation techniques and the principles of the preparation has been defined according to the conventional workflows. But if you're dealing with digital workflows and digital technologies, you have to adjust a bit. Instead of having sharp angles, you have to have more rounded angles, but better and more precise finishing for digital workflows. And the good thing about also the technology is, or the design procedures, the design softwares is, the CAM softwares or CAD softwares can be adjusted to the milling machines or the axis we are using. As you can see, I have just given an example of 3 different burr sets. You can go for a very thin intaglio, very accurate intaglio, to more sharp, more bulky burrs to create room for restorations. All of them can end up with perfect, accurately fitting restorations, as long as you know what you are using, as long as you're preparing according to the set, to the milling machine you're going to use to produce the restoration. All of them can end up with good results. And again, this now is milling, not printing, but with the proper cement gap and proper preparation modalities, the intaglio surface in this restoration, again, is not undermilled, not overmilled, but perfect. And also, we may require, we are using different milling machines, and different milling machines require different milling strategies. We're dentists. We are working in the clinic, and then when we are making the impression and send it to the lab, we don't think about their work, with what type of cam they're using, what type of milling machine they're using, what type of printing restoration procedure they're using. But we have to know, we have to keep that in mind, because all of them are different than each other, and all of them may require different little modalities. This is why we should be always in coordination with our dental lab technician and to have an insight about what type of methodology, what type of material, what type of restoration procedure, a milling machine they're using to make a proper restoration. Let me give you an example about the additive printing technologies. This patient has some fractured filling. A colleague of mine at the university, Dr. Challer, made this, a very brief preparation to protect, and we are going to use a very thin additive composite resin. We go into the software, and when I go into the software, what I do is to choose the STL data. I'll upload them to the cloud. The system identifies the lower arc and the upper arc. All of a sudden, it takes some time, of course, up to 2 minutes, etc. Then gives me an approximate margin line, which I should play with. And also I had the opportunity to adjust the path of insertion. And when I'm done, the restoration is being offered, proposed by the algorithm. And we go into this time the additive technologies. We have used bagel resin here. And as you can see, in 15 to 20 minutes, my restoration is complete. And after that, we're using some makeup and staining and also glaze. And this is what we get in the patient's mouth. When it comes to subtractive technologies, or again, another example of the additive technologies, I'll come to subtractive technologies. The same applies to prosthetic design has been done, offered, and with the help of rubber dam, we are delivering the restoration. I have put this slide to make you aware of something. When you are dealing with digital technologies, digital dentistry, you have two options. You can go model-free or you can go with a model. When do we need a model? Where should we go model-free? My friend, the models are being produced in 3D printers and they have layers in the Z-axis vertically. As you can see, it's very visible in here. Starting from 50 microns to 200 microns, you can have kind of inaccurate models of what you get with an intraoral scanner in the patient's mouth, because with the intraoral scanner, you can have up to 2 to 10 microns of accuracy. But when you have a 2 to 10 microns of accuracy and working on the software with a 2 to 10 microns of accuracy, and you are going to play with, or you are going to adjust this production on a 200 micron accurate model, you may fail. You may have problems. You cannot easily adjust the occlusal context or mesial context or distal context. We are using models not to create everything from scratch. We are using models if we need some staining, if we need some layering, not only occlusal side, not only contact areas, but on the labial side or buccal side. So in my workflow, my daily practice, if I'm dealing with, even for full arc restorations, I do not rely on the 3D printed models. I start and end up with the virtual models, and virtually I finalize everything. And it's more accurate than getting help from the 3D printer because it is not standardized yet. You cannot rely on them to have better contact. You cannot rely on them to have better fit, but you can rely on them for veneering, to adjusting after you have a try-in of the final restoration in the patient's mouth. Same methodology, this time subtractive technique. I'm preparing to go and only the preparation has been made. There is no undercut, and the software produced the design, a proposal. If you need, you can play it. And the good thing about this type of things are when you get one CAD STL from one software with the help of different softwares, you can mail them chairside, or you can send them to the lab and they can provide the final restoration for you. I have a CEREC billing system and CEREC workflow, which is completely closed workflow, but I can use the data of any given software as the final restoration STL. I go into the CAM software of the CEREC and switch this STL to a printable or millable format, and I can still use my milling machine. And I end up with precisely fitting and also naturally looking final restoration with the help of a little bit of staining. It's also possible to go for implant restorations with the help of artificial intelligence, or it's also possible to go for bridge work with the help of restorations with the 3D printed materials. You have the opportunity to make the try-in in the patient's mouth, to go for the final restoration with the zirconia. And the good part about playing with all these type of things are you get better planning, not only better planning, but better trying before you go for the final restoration. The artificial intelligence and also the CAD software gives the opportunity to make the occlusal contacts or making the occlusal penetration correction automatically according to what you get in the end, like having the most contact, or can give you the option to make protecting the natural anatomy. The patient's bridge work has been designed and a 3D printed model has been made. The mock-up has been used in the patient's mouth. 2 restorations with the 1 cantilever to be used for a implant supported restoration in the future. I go to the adaptation. As you can see from here, the cantilever has more contact and I have to protect it from extra contacts. I can use the cutting intersection, adapt set distance for antagons, and all of a sudden, the restoration is being remodeled according to the best fit, or we can also preserve the shape instead of going into the model and instead of having the burrs and making the layering again and again. With 1 click, we can design accordingly. When it comes to mastering the material, the most important part after making the good plan is to choosing the right material in terms of translucency, in terms of strength, to have a better and long-standing restoration. Let's take an example for this central incisor. The 2 laminate veneers I have made 12 years ago. The patient had some issues with her staining and the fluorosis, and 12 years later, she had some periodontal issues, and as you can see, we are facing with a gingival recession. And I go into the smile card again because the patient now wants to have a bit of slightly longer teeth. And when I showed her what she can have virtually, then we decided to make it a little bit of shorter than she was dreaming of, which can fit better, which can be much better in terms of supporting the lip, in terms of seeing or being visible during the smile. And again, all the designs according, as you can see from here, to the motion. And also I wanted to have at least 0.9 millimeters of material to protect the shade, protect the color of the veneers I have made 12 years ago. And this is the end result with the monolithic restoration with the help of liquid ceramics. When it comes to implantology, I'm going to show you some cases, single crown, and also full reconstruction with the help of artificial intelligence, with the help of digital technologies, which I'm using on my daily basis. This is a case we have finished with my dear friend, Dr. Jamilus. And this is a colleague of us. He's a dentist, a very young dentist, very unfortunate accident with the left lateral incisor. Unfortunately, this young fellow had his tooth broken down. We need to have an implant restoration, and we have to go for immediacy if the circumstances are okay. We start with having, through analysis of the CBCT scan, in order to see that if we have enough bone volume for our restoration or for our implant. And this is what we are using, again, on our daily basis to evaluate our cases. This is SAC, the SAC tool by ITI. We classify cases in terms of surgical or prosthetic part. Simple, as you can see from here, is green. Advanced, as you can see from here, is yellow. And complex, as you can see from here, red. As simple actually is not simple, it's straightforward. You just go from A to Z, step by step. Everything is perfect. There is nothing, there's not wastes and biases, there's nothing risky. The high risks are when you have high aesthetic demands, when you have less bone, inadequate bone, when you have more visibility, whatever case, whatever restoration you're using, you go into the SAC tool, you do the revaluation for yourself, and then you have to think that, where am I? As a surgeon or as a prosthodontist, can I handle with straightforward and complex and advanced cases, or should I stop? I'm a prosthodontist who can deal with complex cases, but I'm not a surgeon who can deal with complex cases. My limitation is yellow, which means that I can handle advanced cases, but when it comes to complex cases, I refer my patients to a surgeon. This is very important for our profession. Knowing your limitations, respecting your limitations, and if you cannot handle something, referring them to the right people to make the best treatment for our patient. The idea is not doing our best. The idea is doing what is best for the patient. This is why he is doing the surgery, because he's a periodontist and he can deal with the soft tissue modeling. When it comes to restorations, I'm a prosthodontist. After a nice implementation, I can handle the resto part, the pros part. This is why this is a teamwork. The patient's tooth is being extracted. As you can see, it's two-part, and with the help of the socket guidance and also our planning, we're going to use a 12 millimeter of implant over here. the implant is positioned a bit palatally and a bit distally in order to achieve to have the accessor in the palatal side. But also we see that we have a little problem in the surface on the mesopapilla side, which can also be handled. Pre-made shell is being used to adjust the angulation and the positioning of the implant. The implant is being placed. We have used 3.3 BLC. This is a conical implant by Straumann, which gives us better strength and better primary stability. Okay, you see here, the tip is also collecting the bone, and the implant is being inserted in its position slowly, and in the end, with handpiece, you can see from here how much torque we get. We have more than 35 Newton centimeters, which tells us that we can do an immediate loading. To make an immediate loading, we're using the shell again, and a provisional abutment is being used upon the restoration. The soft tissue is being increased with a connective tissue graft, which has been quite from the palate area. The connective tissue graft is being applied immediately in the time of implantation. And also, we need some Sanogen graft in between the implant and the socket to prevent the bone collapse. And the provisional restoration is shaped according to the biologically sound principles, which has been defined by Ramon Gomez Mata and Oscar Gonzalez, and with other colleagues, the restoration has been placed. And the final provisional at the day of surgery. 1 day later, you still see a little bit of bleeding, but the patient seems nice. We can see still a little bit of problem in the mesopapilla. Again, 1 day later. Now we have, with immediate restoration, this is what we have in the first week. And this is what we have in the 2 months. And as you can see from here, in the meso side of the restoration, in the papilla and the implant, we have collapse. We need to support it with soft tissue, with hard tissue graft, to have a natural biomimetic restoration, to mimic the right central incisor. This is what this intro photo tells. But the reality is not that. The reality is the provisional restoration is loose. The provisional restoration was in contact with the tip of the maxillary mandibular canine, and with the help of this contact, it became a bit loose. And so it is not supporting the surrounding soft tissue as well. So 2 months later, I have removed this provisional restoration. I remade another provisional restoration, this time to support the gingiva from a little bit deeper and trying to mimic the right central incisor as possible. And after enough time, after 1 month, this is what I get. Thick, sound, peri-implant gingiva. Two-dimensional scan. And having the optimal emergence profile, which is convex, the contact area of the mucosa of the crown, which is concave to support and to have thicker peri-implant soft tissue and a straight ending on the crestal side to have crestal stability about the bone. And this is what we get after 3 months. Sometimes we don't need to have extra surgeries. Sometimes we need to rethink, remake, reevaluate the issue and trying to solve the issues only by respecting the biology and making a proper restoration to gain some tissues. Remember this patient, once again, this time the full procedure, the planning has been done. And first I'm going to extract the tooth virtually. This is called diagnostics. The intro scan is being registered and aligned with the CBCT scan. And virtually, I'm removing the central incisor. After that, I'm putting the central incisor on my plan, which is the mirror image of the left central incisor. The implant is being virtually positioned according to the plan to give sufficient room for the labial side, for the peri-implant tissue to be supported. Abutment has been chosen. Surgery. According to the toasters, beyond the gap filling approach, the provisional immediate restoration has been placed and the facial interproximal tissues have been gained by using extra cyanogenic graft to support the tissues. This is what we get after 2 months. The volume perfectly protected. Again, according to the concept of biologically and aesthetically constructed provisionals. And as you can see from here, the implant is positioned almost perfectly according to the plan, with only 0.7 millimeters of distal variation and up to 3 degrees of triangulation accuracy. The next step is choosing the right material. We have many options. We have many monolithic options. From right to left, we see amber mill, which is a lithium disilicate with different translucencies. We see Bion A1 from Almangirba, zirconia, Genex, zirconia, Bion A2, zirconia. And in terms of having the color at A2 and also the translucency, my choice was Bion A2, which was milled in ceramic matron. And this is the end result of the patient central incision. She never had one single day without any restoration in her mouth. And she's a very happy patient. This is the idea. But for more complex cases like this, we still need a plan. Not only we need a plan, we need to create a virtual, the digital patient in order to achieve the best planning. What you have seen, as you have seen here, is the angulation. When you take a photo of the picture of the patient and you send it to the lab, the patient or most of the human mind tend to understand the correct occlusal plane and do it accordingly. But the reality is way different than that. Already he had some issues with the occlusal plane in his mouth. This is why we are using the facial-driven implantology. Another good software support and from the artificial intelligence side is using them for diagnostic aim. This is cranial catch. You upload a CBCT, you upload an X-ray, and the system, the algorithm, detects the teeth, detects the surrounding tissues, detects the caries, detects the risk of problems. 100% right? No, of course not. It needs to be supervised, but it gives you a checklist so that with the checklist, you never miss, you never skip anything for a thorough understanding of the patient's condition. Then I switch to, again, SAC tool, the SAC tool. And surgically, it seems to be complex, and prosthetically, it seems to be advanced to complex. This is how it goes. And then I go into the patient's mouth again. I create the virtual patients, intraoral scan, the CBCT, and the face scan. All of them get together, are being merged in different softwares like SmileCloud, like Co-Diagnostics, to create the patient. And then I go to SmileCloud for the final prosthetic planning. This plan is going to be transferred to the Co-Diagnostics to the proper implant plan. My friend, these images, those videos are being produced by artificial intelligence, only from a photograph. And what you're seeing as a three-dimensional design is what I have designed in the SmileCloud. What I designed can be exactly reproduced in artificial intelligence video, and so that I can use this video as a tool of communication with the patient. And not only with that, I also take care of the occlusion and the motion. And I get this STL in this final positioning. I go into the surgical planning platform for diagnostics. I virtually install the implants. I virtually choose the abutments. I virtually extract the tooth. And I make a surgical guide and also a provisional restoration to be used in the patient's mouth immediately, right after I do the surgery. The surgical protocol has been defined. What I'm going to use is already been planned and decided. And way better than that, with a virtual implant insertion, I can also create the virtual implant impression before I do anything in the patient's mouth. A restoration has been produced, and right after surgery, I have installed the provisional restoration so that the patient doesn't have any time without any teeth. When he is ready for the final restoration, I remake a provisional restoration for the upper jaw and the lower jaw to see the contacts, to see the soft tissue integration. And as you can see, we need to have some adjustments, some corrections, like the central incisor should be reduced, and we need some add-on on the left premolar area. This image has been done on iPad app. This is just a prefabricated image, but the image can be used to produce the final restoration. This is reverse scan by Revex, the provisional restoration, which defines the aesthetic and also the occlusal relations, which has been approved by the patient, is being scanned. So with the reverse scanning technique, I will reproduce with the corrected version of the restoration by using monolithic zirconia. The monolithic zirconia is being milled. The texture has been created. You're seeing the holes for the wire base, the titanium bases, they are being luted, and the prosthesis has been delivered to the patient. And now we see from 0 to the final day, the transition with a true planning of the patient. Nothing is a surprise. Everything is sound, planned, and aided by artificial intelligence. Every tech, every novelty creates a hype. This is a very nice graphic. I'm happy to show every presentation I make by Yoda. In the next 5 years, quantum computing, robotics, digital twins, and VR is going to be triggered and going to create a hype, he said 2 years ago. We see that now. The robotics and the VR is already in the hype, especially in the implantology. Image language analysis, which you're using, LLM, the senses, social data, dental medicine, decision support. They have created the hype, but if you're not using them on the right track, they create this illusion like we had once with the additive manufacturing. 2 years ago, additive manufacturing was not in that position. And now we are enlightened by using the additive manufacturing, and it became productive. Every technological novelty creates a trigger, creates a hype, and creates some disillusion. But after some enlightenment and understanding the positive and negative sides, they become productive. This is very important. Implement novelties, be patient, and try to understand and try to accept your mistakes and learn from your mistakes. Most people overestimate what they can do in 1 year and underestimate what they can do in 10 years, said once Bill Gates. And we can change this quote a bit. And what most people overestimate what tech can do in 1 year and underestimate what tech can do in 10 years. Technology is here to help us, but we have to understand it and we have to use it, not only to use the technology, but to use it on behalf of the good treatment, on behalf of the good of the patient. I want to thank you for your attention, and I want to thank you for the opportunity to share my passion for digital dentistry, and I'm ready for any question you want to ask with my lovely colleagues. Okay. Thanks so much again, dear friends. It was fun to be with you. Hope you enjoyed it.
Okay, thank you, Doctor. Dear participant, if you have any questions, you can ask.
I've opened up the conversation so that if you ask, I can see here. Sometimes it's not easy to digest all the novelties and digitalization all of a sudden. It took me more than 11 years. So sometimes it takes some time. But I'm sure that in 2 years or 3 years, you'll be knowing more than me. This is how it goes.
We hope so.
I'm sure. I'm sure.
Doctor, we have a question. Sophia, there's a question in the comment box, please.
Okay, there's a question saying, is vertical preparation better?
Is vertical preparation better? Actually, you have to, if you are thinking of vertical preparation in terms of what, for the several indications, it can be better. It's not better for a 20-year-old patient. Why? Because the patient has not lose anything. With every year, we are losing some amount of our animal, which means that if you're 40 plus, 50 plus, You have already lost 0.3 millimeters of your enamel, which means that with the vertical preparation, with minimal preparation, only adding what you have to the tooth surface, like a laminate veneer, with the monolithic restorations, you're not only protecting what you have, you're also providing what the patient lost. So yes, for certain indications, it is way better because you are going to give the patient what they already lost without touching them or touching minimally. And with the material, we can, when it comes to laminate veneers, 0.3 or 0.1 millimeter thickness may be sufficient circumstances, which means that we do less preparation. But if you're a young patient and you have some inclinations and still want to go for only for vertical preparation, which means that then you may have to prepare more than you need. So when it comes to some crowns and restorations for monolithic restoration, it is. But do not forget that vertical preparation is a very precise procedure because you redefine the margin, redefine the biological sound structure. So for certain cases, yes. But for technicians, it's not easy to manipulate. It requires material knowledge. It requires sound materials. Otherwise, you can have some leakage. You can have some mechanical problems. Why do we use the margin? To gain structural durability for the restoration. The margin is not only to define, to protect the tooth and for the periodontal protection. They also, the margins are for the restoration to give them strength. It's very popular because if you are doing with vertical preparation, which means that you don't have a preset or very defined margin, then anybody can do any restoration and you can produce because you're defining where it ends. So you make more, the companies sell more. It's skeptical.
Thank you, Doctor. There is another question saying, what digital skills should undergraduate students prioritize to stay competitive in modern prosthodontics?
Very good question and very hard to answer. Why? Because I think you have to learn on your own. You have to teach yourself because I don't know, there's some certain courses and there's some certain facilities where you can adapt your technology, where you can learn, but there are very few. And even if you started creating a curriculum, let's say our example, we have created a curriculum. And I do teach PhD students every year because I'm a PhD coordinator. My classes are changing every year. So every year, my students are should attend to those classes they have already taken because they have to renew themselves. But when you create a course, a curricula, it's not that easy to remake it all the time. So I think what I suggest is, first, gain literacy about some certain protocols and whatever material you're using, whatever intro scan are using. Internet is the highest source of information. This is very important. Instead of sticking with one's mind, do not follow me, do not follow X guy and Z guy. They may lead you to different roads. So take a look at what I'm doing. Take notes, what I'm using, and go deep dive, go into the YouTube, go into the company, but before that, also go into PubMed, if the workflow is working or not. And then you create your own curriculum. It's very sad to say that just go there and take this class and go to that courses. It's much easier, but believe me, there are very few. I cannot tell everything in words because it's very challenging. I can give you many examples, but most of the time when you're in a university, let's say at a US university or in UK or in Switzerland, you have some arrangement with a certain companies, you have like say CEREC system or 3Shape. Not every single facility has everything on their own and make a comparative study or understanding. What you have, what you teach. This is the challenge. And when you're following one person, if a QL of, let's say, Straumann, so, and then I'm going to end up with a Noble guy or like a Sirona guy or a 3Shape guy. We see that in real life. I'm always talking about the real life, okay? We are just 4 people. I don't know how many people we are, but this is very important. When you are trying to start with the technology, it is challenging. But you can do one thing. You can go into the PubMed, go certain keywords, and you're going to see some certain publications by some people. Those are the ones. Let me give you an example, like Quest Center. Maybe you can go to Quest Center to have a very good education for some course. But the good thing is, in the digital era, you can create your very own course. It's very easy. It's not that hard. The hardest part is having the equipment. The intro scanners. You go into the fairs, go into the companies' free lectures and just try them out. You will not get lost. Only thing you have to remember that do not get into the fear of missing out. You're not missing anything out. Even if you're going fully conventional, you're not missing anything out. The idea is producing, selling, or treating the patient in the right way. So when you are asking for what class I should attend, there's no one single answer. Go for online courses. Just take one lesson, just one lecture. Go to OHIS, go to Dental XP, just go to ITI, which I highly recommend. See one example and learn something, take notes, and compare it with the relevant and final recent findings. Go to the PubMed and see that if what they're saying is relevant or not. It's a biased view or it's a fair view, then you're going to know who to follow, who to proceed. It's a long and very complicated answer, but maybe it's an honest answer. Wish I could tell you that go to this university, go to that course, and just everything will be fine. There's no word like that, unfortunately not.
Okay, there's no more question. We deeply thank you and appreciate your effort and willingness to share your experiences with us, Dr. Ali. Thank you once again for being with us today.
It was a great pleasure, and knowing you, I wish you the best of success, best of luck, and best of everything in your life. And I'm very happy to with young colleagues like you, and I really appreciate that what you are doing right now, because when I was 30 years ago, we did not have the opportunity, and now this is what we can do with the technology. I'm very happy to be with you.
Thank you. We are happy for having you today, Dr. Ali. And we would like also to thank all participants for attending today's sessions. We look forward to seeing you in our upcoming webinars, and kindly note that the QR code for attendance will remain visible on the screen for 5 minutes only to allow participants to scan it and complete the form. Thank you all, and bye-bye.
Have a good day. Bye-bye. Thanks so much.
Bye.